Now I think I got the most difficult task, I think, to talk about artificial intelligence in clinical decision making, which can be very controversial as itself, right? So in my capacity at the Ministry of Health, it's a huge portion of my life is dedicated towards dissecting the complex intersection of clinical practice with health informatics. So I want to tell you that we are currently standing at crossroads, professional crossroads, where digital technologies, digital health technologies are shifting from a speculative optimism to a pragmatic necessity now. So I'm not going to talk about today in this session about artificial intelligence as a futuristic conceptual work, or I'm not going to get you indulge in this hype-driven adoption, which can obviously cloud our clinical and professional judgment very much, right? So instead, I'm going to talk about how artificial intelligence, when it comes to algorithms, I'm going to bridge the gap between the precision of the algorithm with the clinical safety. So we are going to talk about socio-technical regulation and intervention as well, that part as well. So you have to know, when it comes to AI, there are algorithms. It's one thing to be AI to be very precise, accurate in a very silent, very temperature controlled like this hall, air conditioned laboratory settings. And it's another thing that the AI algorithm to be safe in a messy, humid, tension-filled hospital setup like in Sri Lanka, right? So this brings us to our main clinical paradox of which can challenge our over-enthusiasm towards digital transformation. So often we hear that the mathematical brilliance of many mathematical models, right? But yet we ended up in a very clinical paradox. So the main question is, can a statistically accurate algorithm still create an unsafe clinical decision? What do you think? For health informatician, it's not a big question for us because it's a matter of knowledge that everyone who works in a clinician, a doctor, all experience this every day during their lives. So we hear so many models coming up with the 99% accuracy, near perfect area under the curve. So, but yet fails spectacularly when it meets the fragmented data and messy workflows, right? You know why? Because the main reason is clinical safety is not an isolated attribute of a software. Have you seen any software claiming we are providing clinical safety? It's safe like that. Any software? No, I'm pretty sure in their technical documents they never mention anything about safety. The accuracy, they will speak a lot at length, right? So when we view, because we can consider as a socio-technical intervention, and when we view AI as just a product, then we are going to miss the entire point. Because this is a team effort between the humans and machines, right? It's a symbiosis. So imagine if the underlying data is disconnected and there are so much of delayed alerts because of the network failure, patchy network. And imagine the user interface is very cumbersome. You have to click so many things, so many multimodal steps. And imagine that setup working with an intern medical officer handling an emergency situation at 2 a.m. in the morning, right? So the safety depends, because the thing is when even the most superior, best AI algorithm will provide fragmented results in that case. So the safety, if you talk about safety, it depends on several parameters. One, although of course it's apart from the accuracy, It's the main important part is how it aligns with your existing workflows, and how the knowledge of those model limitations are properly conveyed to the user or clinical doctor, right? Imagine you given an AI model or maybe an AI clinical decision support system, and the doctor doesn't know, and he expects that AI model to diagnose so many complicated things, but if you don't know the limitations also, then it's also a problem. And next part is like it depends on whether that model is properly clinically validated in the local OPD setting, right? So to navigate this landscape, I think we have to look at the patient's journey from the initial presentation to the intervention by us. So when you visually trace the pathway from presentation to intervention, we can see there are we can divide into 3 blocks where the AI can typically intervene. One, this is like a general patient workflow. So one place is trial chance screening, other one is continuous prediction, and the third part is the decision support. So what you have to know is at each of these stages, there's an alteration of clinician's cognitive load, right? Cognition, it changes with every interaction, right? If you take like trial chance screening, if you use AI, sometimes the AI intervenes before the human even acts on, right? So it captures so many images and triages the patients and gives you what we have to see, which patient we should see first. So this has actually shifted the clinician's role from a primary filter into a secondary validator. That's how the role shifting has been done. And if we talk about continuous prediction, so this happens especially in the ICU settings, maybe emergency departments. So it acts as monitors alongside human cognition, and it extracts data continuously from electronic health records. Think of it as a colleague of yours, a new trained colleague who doesn't sleep, who doesn't get tired, who doesn't get hungry, and continuously look after the patient. After the patient while you are busy with other patient during the same ward round. Mindful, I have to be very tactful when I'm using words. so it's like, but then finally we have the decision support. That means when it comes to order entry, it kind of modifies our order entry actions by providing guidelines, trying to prevent medication errors, and so on. So, when it comes to each of what you have to understand is each of these pillars, I think the main stages, requires a unique level of trust and human oversight between the human and the machines, right? So, if we are to manage them safely, we need to understand the anatomy of these different algorithmic roles. I'm not talking about the anatomy of the algorithm. I'm talking about the algorithmic roles, and why intended use is most important characteristic for any clinician when you are dealing with AI. So, to navigate this landscape, it's helpful to divide these roles into 3 distinct parts: finding the disease, forecasting the risk, and supportive actions. So when we talk about finding the disease, we are looking at mainly diagnostic AI. Maybe it can be pathological slides, can be mammographic devices like that. So forecasting risk involves kind of predictive analytics, which can predict the trajectory of ICU patient, whether the patient is going through a sepsis or that kind of thing. And supporting action refers to clinical decision support, which help us to adhere to guidelines and to prevent medication errors. So you must ask, I mean, I think in the main key point here is any clinician must always interrogate their AI system given. You must always clinically, ask what is expected of this AI system. Is this system is doing the correct thing what I am expecting? You have to be always critical about it, no matter how much it gives, right? So because the main reason is, imagine a diagnostic tool built for a high resource setting in maybe a private clinic in the West. And it will always behave differently when you try to apply it for a rural Sri Lankan village with minimal setup and maybe a different patient demographic, right? It can be chaotic. So the evidence shows that the strongest gains around AI is facilitated when these specific roles are clearly defined, right? And as you know, in terms of AI algorithms, they act best when the scope is narrow and the roles are tightly bounded, and when the data is so much enriched. I'm pretty sure I can give a practical example, maybe students-wise. When you're given a research topic, what you're going to do first? Type it in the chat GPT, give me a thesis on telehealth. So you must have tried that, right? Yes, I can see the faces. So I'm pretty sure it creates a lot of noise, right? There's a huge difference between when you're doing the prompt engineering, giving just a 1 or 2 words prompt, and 2 or 3 pages long of prompt to narrow down your scope. So the global evidence is very clear. As I mentioned, AI always excels when it comes to tightly bounded, data-rich, narrow kind of tasks. So also we have seen very high clinical validity, in most of the visual intensive tasks when it comes to AI, such as when it comes to radiology and maybe retinal imaging. In these spaces, you can say AI can process thousands of volumes of repetitive scans to detect anomalies, to kind of detect advanced cancers and stuff like that as well. However, if you put the same AI technology into open-ended clinical reasoning, imagine how it behaves. Imagine you ask the AI to go through a patient with multisystemic disorders, with 5 or more like clinical morbidities and elderly, so many social issues, how it behaves, right? It's go haywire, right? So we must kind of recognize the fact that the main strength of evidence is currently sitting on with AI used as a anomaly detector, not an AI doctor, right? So to get into these evidences, it's useful to see the Masai trial. So Masai is a randomized controlled trial which was published in Lancet in 2026, released recently. It involved about 100,000 Swedish women. They were undergone a process of mammography screening. So they compared the AI-based mammographic screening against traditional human reading by using 2 dual readings by the radiologist. And as you can see, the results are victorious. It's gold standard right now. So you can see 29% increase in clinically relevant cancers detected, and especially there was a 12% reduction in aggressive interval cancers between screening, which has the worst prognosis because they can be missed during the interval scans. But when it comes to health administrators and policymakers, so these figures might be like, so what? What's in for us? So this is where the main important thing comes in. 44% reduction in human radiologist screening work overload. That's very important because in a context like in Sri Lanka, where specialists are very scarce, I mean, it can be attributed to brain drain, I mean, so many issues like that. So it's very strategically important for policymakers and administrators, this workload reduction. So imagine, as one of my colleague who is a radiologist, he mentioned that looking at a normal radiology scan and confirming it as a normal one is the biggest challenge. Because if you have something, then you can focus your treatment on. But to comment it as a normal one, that's the biggest challenge. So this kind of models helps you to, to eliminate the fatigue the radiologists may have by going through so much of normal scans and focus on which are very complicated scans. So which can reduce the kind of a fatigue and makes the radiologist's life much better. So the challenge is for Sri Lanka is whether we could adopt such things into Sri Lankan setup. So Sri Lanka at the moment at the policy level, we are exploring autonomous task shifting paradigms to address these specific needs. So take this IDXDR system. It's the first FDA approved autonomous AI for diabetic retinopathy. It doesn't just assist, it's diagnosis. Also, when it comes to Sri Lanka, there is a pilot project going on with the diagnostic study using Remedio for NM10. It's a kind of a handheld phone-related device. It's a smartphone-based handheld camera. So this is a game changer for low-resource setting and the community reach, where you don't, when it comes to diabetic retinopathy, you don't need so many specialists in the community setting, even for screening purposes. But even this study also had some limitation. When you read that paper, you will understand that they mentioned about the clinical nuisance of about 60 to 70% of the images they got is ungradable because of the maybe elderly cataract people in the community setup. So one of the intervention they did was use the mydriasis process to dilate their pupils. Then that ungraded proportion decreased down to 15%. So what does this tell you? Anyone? So that means even the sophisticated AI needs human protocols, right? Human protocols. They need to be assisted by humans at the moment. So when we move on to the intensive care unit emergency departments, the goal of AI kind of shifted towards the forecasting physiological collapse before it happens. And there was a nice study by some local research group. They used the Sri Lanka dengue cohort, best topic nowadays. They were able to develop a model to detect the plasma leakage 96 hours within a 96 hours window of first onset of fever. The most fascinating thing about this study was they didn't use any high cost biomarkers or any exotic biomarkers which we cannot be used in every patient. They used simple things, 5 low resource clinical parameters. They used hemoglobin levels, hematocrit levels, lymphocyte levels, AST, and the age. So the thing is, it was this research was done, but the thing is that data set still sits on a database, but nobody uses it. So when it comes to Sri Lankan cultural context, I think we are losing a huge value by just leaving the data as it is with never using, which comes to the most important part, where the AI human handshake happens. So I'm going to talk about a TRUE's implementation study at the Johns Hopkins. So what they have done is AI, they have integrated AI into their workflows. So fascinatingly, it has given victorious results. about, I think, 82% of sensitivity. They have developed a 5.7 hours median early lead time. That means almost 6 hours before it can happen, an event can happen. Imagine in ICU, 6 hours means it's like lifetime, right? And also they have the 18.2% reduction in patients' mortality as well through the TRUTH implementation study. And this is not the secret, the magic word here. It's 89% provider adoption and active alert evaluation. That's the secret here. Because how they have got it done is they have integrated the AI workflow into their existing unique workflow. So whenever you get an AI-based alert inside, the doctor immediately runs to the patient. And maybe if there's a warning of sepsis, they start antibiotics, fluids, and so on. So there was very good response time. So that's kind of highlights that accuracy or maybe efficiency. I mean, rather than those part, the provider adoption is the most important indicator for see the success of AI adoption in when it comes to clinical settings. So it's not a mathematical sensitivity even. So if the humans are not willing to listen to AI's insights in a, let's say, tired, distracted settings, then it's going nowhere. So also this is a success story, and we could compare it with the utter failures as well. If the TRUTH study is a success, we can call the EPIC sepsis model, ESM, as it tells a different tale. As you can see, their sensitivity has been dropped from 82% for 14.7 when it comes to compare with the TRUTH model. And imagine 0 hour late time, median late time in 50% cases. What does that mean? That means 50% of the time, when the alarm, the sepsis alarm fires, by that time the the doctor has already diagnosed and started the treatment in 50% of the cases. That's kind of failure has been observed in this EPIC sepsis model. So why is the reason? Because this was carried out in a very rapid manner, and they have integrated with a very commercially available EMR solution, and they haven't done any local validation. The patient demographics were changed, and there was a data set shift, and there was a black box approach as well. So you have to understand is when the algorithm is trained on one population and deployed in another, it always results in collapse, right? And imagine when it comes to alert fatigue, imagine when you're a clinician, you had to deal with 92 alerts within a given shift. Then actually the 93rd alert becomes actual real one. So your natural tendency is you are conditioned to ignore that, right? So this is how clever technology makes us idle or condition our cognition as well. So we must be honest in our appraisal. So most decision support systems are excelled in process efficiency and standardization, but not so much in hard mortality outcomes. So they are fantastic. The AI is very fantastic to ensure that the treatment you are giving is perfect, whether they are according to proper guidelines, checklists, and everything. But when it comes to the hard mortality outcomes, they get confused. For example, in Kenya, I think there was a study by AI Consult, which has reduced. They have reduced the diagnostic errors and the efficiency medical errors down to 13% and 19%, which is victorious when it comes to process efficiency and standardization. It will be applicable especially for players like an intern working with limited supervision like that. But the thing is, the core rule remains the same. even you can have the most sophisticated AI neural network working in your hospital or your clinical setup, but if the intern has to go through extra mile, maybe several more clicks and maybe several more user interfaces, it's destined to fail. So this is why the psychology of human-AI interaction matters. When you talk about psychology between these interactions, there are two governing domains: automation bias, automation complacency. So what do you mean by automation bias? Automation bias means the AI model gives you an insight, and but still you follow it, and in the back of your head you have this critical gut feeling, intuition that something's wrong somewhere. So, but still you decide to follow that. So that's what we call automation bias. And what do you mean by automation complacency? That means you get an AI insight and you just idle, okay, let the AI figure it out. I can't be bothered, and you're already cognitively tired. So it must be a good model. Let the AI do its job like that. So the danger part is, so imagine you are working at an ICU and the AI insights give you to treat you as pneumonia, and you stop looking for any life-threatening issues like pulmonary embolism. That can happen. So this is how, in large context, this is how, those algorithmic conditioning can change years of experiences which has been embedded in a proper clinician. It can erode their experiential judgment by these algorithms as well. So there's a thing, coming up with the WHO, which I'm working on, HTC and kind of thing. We kind of use explainable AI. Do you think explainable AI would work? It's just that I think it's a digital placebo, right? It just gives an AI an excuse to make the errors they want to make, right? So it's like, I'll tell you why is that. There's a publication in the JAMA in 2023 by Jabbar and his colleagues. They did an interesting study, very eye-opener. They introduced exact biased AI model to clinicians to find the accuracy of their diagnosis. So the alarming fact is, the baseline, without any AI models, they performed about 73% of accuracy. After giving them accuracy with biased AI, then that accuracy dropped down to 61.7%. And when it comes to explainable AI, that means they gave reasoning and with probably heat maps with the AI to the kind of humans. The alarming fact is it only increased about 1 or 2% from the total bias versus the explainable AI. Because you have to know, as human nature, as academics also, still, I think we do the mistake. When we see a very good graph, maybe if we say a proper scientific, looking like scientific, and maybe a mathematical model, we tend to believe it's true, right? Without sometimes, we kind of lack the ability to critically challenge that part. So, that's where so that kind of gives an impression that using explainable AI is not the silver bullet at all. So this is where we have to go on to the patient-clinician AI triad. For the Agency for Health Research and Quality has proposed this model that we should move away from the patient to doctor direct relationship to patient AI and provider relationship. So in this case, AI is an active team member. It should be heavily monitored and it should have proper boundaries. We should ensure that AI doesn't act as an oracle of all the diseases and stuff like that, which everyone will blindly follow to. So, and sometimes the AI model should not drag the clinician's judgment into their level as well. So there are kind of regulation, safety protocols as well. So we should treat the AI not as a product we buy, consume, and just forget. We should always keep it as a life member who needs continuous maintenance. So to keep this trial safe, so the AI governance should be a closed loop quality system. It should be continuously validated, it should be monitored, it should be deployed and recalibrated and validated. It should keep it should be keep on going on, right? So I think this roadmap framework and these IDA guidelines have given the proper blueprint on it, maybe if you need further reading. So when it comes to maturation of regulatory oversight, I think according to FDA's latest guidelines, there's a huge explanation between the thin line between the non-device softwares and device softwares that needs they enforce that it needs strict regulations. According to their guidelines, if any AI device, if it cannot be mainly explained by a clinician, it should be fall into the medical device category after proper validation. That's their guidelines. In Europe also, I think they have an AI Act. It classifies medical AI as high risk category, right? And when it comes to WHO, it talks about the ethics and human rights primacy becoming a very center of all the digital health transformation and AI related stuff. And I think the recent development from FDA is they have shifted to life cycle oversight and predetermined change control. That means the vendor has the right to change their algorithm, update algorithms continuously without having to go through the tedious process of approvals, but the conditions and all those things are pre-agreed before. So how it affects Sri Lanka? I think Dr. Sasit has kind of given you a massive input on how our Sri Lankan healthcare digital health context works. So at the bottom there we have the digital health blueprint and digital health guidelines. So those things kind of provide the bedrock for it. For things like electronic medical records, master patient index, personal health number, and the Personal Data Protection Act, and FHIR, and HL7 interoperability standards, those are the pipelines where the AI data flows. So we have to consider the strategic opportunity we have in the state sector, because we handle about 50% of the outpatient cases, and maybe around 90% of hospital admissions are done at the state sector. So its centralization is kind of massive advantage for scaling up and validation of AI tools in this setup, especially in the government sector. And also we must avoid this term called pilotitis. We do a pilot and fail. It's an epidemic now, right? So it was example by, I think, back in the district hospital Dompe, they had a fabulous system back then, but ended up failure because of lack of supporting staff and the scaling up protocols and interoperability. So we should avoid those things happening in Firao. And also, I think as Dr. Susit mentioned, the Data Protection Act gives legal safeguards. And also, one of the optimistic factors is that even Ceylon College of Physicians, they're also doing a white paper on AI clinical governance. And I think it's important to involve colleges like Sri Lanka College of Health Informaticians, Health Informatics Society of Sri Lanka, and even IIHs can facilitate those kind of forums to give a unified approach towards this AI governance. So, as we conclude, I want to leave you with 3 messages. Augment the judgment, validate locally, and monitor closely. The goal of AI is never to replace the doctor, but to augment our judgment so we can provide better and safer care. But we should, ensure that every tool has to be validated to our local context and maybe using our own patients, own blood samples, or own data. Because we see patients as, we see the subtle changes, but the AI see the data points. So always have that human touch. So ultimately, ultimately the clinical AI, we have to know is that it will never be judged by the precision or accuracy of the model, or maybe the hype of the marketing strategy. It will be judged when it improves the patient's mortality or outcomes significantly. So, if we focus on safety, equity, and human AI partnership, we can use these tools to build a health system that is not more than efficient and fundamentally more human. That's where I leave you. Thank you so much for your time.